Yeah, so exciting times. We have a bunch of new medications available to us, and some coming up on the horizon for management of non-muscle invasive bladder cancer. I mean, traditionally we've had obviously BCG, we've had Pembro now for quite some time, but our options have been quite limited. We've tried to put patients on clinical trials, and now we're seeing the fruits of those labors with approvals of several new drugs. And those drugs are now on the market. We're beginning to use them. One example, it's Adstiladrin, nadofaragene firadenovec. That's been in use since November of 2023. We're gaining experience with it, and that's been a great addition to our armamentarium here. We have the exciting TAR-200 device in various clinical trials. That's not been approved yet, but we have the Sunrise 1 through 4 studies with additional studies coming forward. Another recent approval has been Anktiva. And Anktiva is an IL-15 superagonist that's used along with BCG. The results were presented at the AUA just recently in May, and now very soon after it's become commercially available. So that's also exciting that we have additional options for patients. That's another exciting avenue of research, is the biomarkers in the urine. We've had ctDNA available now for some time in the serum that we're using clinically now, and we've been looking at biomarkers in the urine. There's several of them. We're looking at urinary tumor DNA, much like the circulating tumor DNA. There are several companies, I'm not going to highlight any one in particular, but there are several working on this, and they're being incorporated into the future clinical trials. So we have mounting data available, and as we incorporate them into these trials, we'll get more and more data as to what is the predictive value of these things. We've been working on some as well at our institution, and I think these will all help to have us make decisions on the future management of the patients as we get more and more information. Cytology has been around for so long; it's just got such a poor negative predictive value. We've relied really too heavily on cytology in the past. So I think this is the wave of the future, is using these urinary biomarkers to help us make these decisions. Yeah, I think we still don't have robust predictors. We know that patients with CIS initially they respond quite well. We know that we need to do a complete transurethral resection of the bladder tumor for best response to BCG. Other than that, we really don't know who the non-responders are. We know that up to 30% of patients with CIS will not respond to BCG. It's still an area of research to see, can we predict this from the beginning? Can we add a checkpoint inhibitor to BCG? And we have the CREST trial that will result relatively soon. Can we go to gemcitabine docetaxel from the beginning? We have another trial there to see whether that's equivalent, or whether some patients will respond better to that therapy, intravesical chemotherapy, rather than BCG. So I would say right now it's still the standard of care all around the world is intravesical BCG for all comers. And we're beginning to learn, we're going to be learning which patients perhaps would respond better to alternative therapy to BCG.